All right, welcome to the Strength Athlete Podcast, episode 4. We have Eric
Three.
Bodhorn, Bryce Lewis, 3. Oh, this is 3. I'm going to start that over. Welcome to the Strength Athlete Podcast, episode 3, take 2. We have coaches Eric Bodhorn and Bryce Lewis, as well as a special guest and personal friend of mine, Quinn Henoch, who is a physical therapist based here in Southern California. If you guys want to say what's up.
What's
Hello.
up?
How's it going?
Yeah, so
Very
for those
literal.
of you who don't, yeah, for those of you who don't know, Quinn is a physical therapist, very highly esteemed in the barbell community, especially, and not without reason, in my opinion. So, Quinn, if you want to tell us a little bit about kind of what your background is, what got you into physical therapy, what athletics you were involved in coming up, I know we're all interested to know.
Yeah, sure. I'll run through that real quick because it's not that interesting, my background, but it's similar probably to a lot of sports-oriented physical therapists or coaches. I grew up playing sports in high school, played football, basketball, and ran track, and then played football at a small college in the Midwest called Valparaiso University. Played a few years there, and I was a defensive back, and then it was around that time, it was right after graduation, is when I kind of dived into the competitive barbell sports. Dabbled in my, tired of being outmatched by women, 2 weight classes below me, and so sport of weightlifting, what I've specialized in for the last 7 years, and so weightlifting being the snatch and clean and jerk, and it really melded to my attributes nicely. The speed qualities, not having to be super strong. Obviously, strength plays a part, but I just enjoy that sport so much, and it's kind of been a passion of mine. So that's been my athletic background since college football has been the sport of weightlifting. But here at Juggernaut Training Systems in Southern California, we work with all of the barbell sports, weightlifting, powerlifting, CrossFitters, strongmen, and any strength and conditioning athlete in between. So that's kind of that.
Okay, very cool. So, to start with, your background was football specifically, and if I remember right, you played receiver, right?
I played a little bit of receiver in college. I was mostly a defensive back, so just a little gnat, running around and cutting people down, uh, trying to pick passes off, but usually just batting them down and being good with that. And then after undergrad, my degree was in exercise science. I took a year off and I just worked at several facilities as a coach, and wanted a little bit more in my education. I felt like there was a little bit of a gap. When somebody would come to me with injuries, I just honestly didn't know what to tell them. I'd say, okay, well, let's not do that, and let's see if this hurts. And then that was the rehab, because that's the training that I had. And so I thought that physical therapy would be a perfect bridge. I would still be able to do the things in the performance realm, but I would have this broader scope of knowledge, I guess. And so in 2010, I went back to PT school and to the University of Indianapolis, and that's a 3-year doctorate in physical therapy. And so I graduated in 2013 with that, and started rolling from there.
Very cool. So, totally lost my train of thought here. Oh, actually, this segues into a great question that we were planning on bringing up later. So previously, that was back when you were running Dark Side Strength, right?
So yeah, so I was with Ryan Brown. His Dark Side Strength was his baby, and he's a good friend of mine, and we coach at the same gym. And when I went to PT school, he ended up owning that gym. And then when I graduated, we started working together. That was in Louisville, Kentucky, is when he and I really took off with Dark Side. But yeah,
Okay.
so that 2012 to 2015-ish,
Okay.
yeah.
So, I mean, that wasn't the question, but that's
Oh,
fun little tidbit.
okay.
This is fun to know. But the reason I asked that, the question itself is, as a coach, and you really have probably the most insight into this of anyone, because you literally started out as a powerlifting coach and transitioned into being a physical therapist. So, based on your knowledge now, what would you say is the scope or the limitation even of what a powerlifting coach can do? And like, if me as a client, what should I expect my coach be able to do when I have kind of an in-gym boo-boo?
Yeah, I wouldn't even say it's limited to powerlifting. I think that just strength and conditioning coaches and trainers in general, they not necessarily having a plan B or a plan C in their back pocket. The movement is whatever's programmed as the movement. Not necessarily respecting when somebody is a little battered up or fatigued or in pain, and not necessarily knowing how to modulate volumes or have movement modifications. They don't have to try to fix. A coach doesn't have to try to fix somebody. That's not their job. Their job is to boost performance. But it's very rare that you're going to have an athlete who's just 100% all the time. It doesn't happen if they're training hard. And so, as a coach, you've got to have a regression and a progression in your back pocket at all times. In case there needs to be a change on the fly. And that was something that I, as a coach, didn't necessarily have. I could write a program, I could plan out an entire year, and I could coach the lifts. But as soon as something went wrong, if somebody was in pain or a weird shift in their squat or something that was just throwing them off, I didn't necessarily have any other options. It was I guess we'll lighten the weight, or as opposed to let's work on this regression. Let's use tempos. It looks like a tendon type overuse versus a inflammatory sprain, that type of deal. And so my physical therapy background has offered me the ability to differentiate between these issues as far as the actual injury itself, and then kind of the coach in me can then integrate that into what modifications in the program need to be made, because that's ultimately going to be the fix, is modifying the program for the long term. As a practitioner, you make sure they don't have back cancer and nothing is like snapped off of the bone. And other than that, Mother Nature is going to do her thing. Training needs to be at that point not getting in Mother Nature's way. And as a coach, the coach needs to know how to modulate the variables in the program, to allow that to happen.
So, Quinn, I know we're going to get into this quite a bit in terms of talking about how to tell if an athlete's injured, but with where you are at present, are you able to kind of see the writing on the wall and being able to see kind of like signs that someone is at a higher risk of getting injured? And can you speak a little bit about that?
Yeah, I mean, I guess we need to define injury, as anything that is going to keep them out of training. Obviously there's probably pain associated with it, but missing training days because of an issue, I guess we can define that as injury, and that can be chronic, acute, sprain, strain, lots of different, it's a big umbrella to say that. But I think in general, if from a psychological standpoint, if they're apprehensive, so not everything even the performance doesn't even have to dip yet. But if somebody is apprehensive about a certain position or movement, or as a coach, you can kind of see them hesitating, they're not moving with the same tempo. Maybe it's still the bar path still looks the same, but it's moving much more slowly. You can kind of dive into that. And obviously fatigue can be a factor there as well, but that can predispose somebody to an injury. And so, the first thing is apprehension that the athlete is either expressing to you or demonstrating in just the quality of the movement. The nature of the symptoms, you've got to differentiate between something that's kind of, I guess, a normal soreness or a normal achiness that goes away after you're nice and warmed up, and doesn't, maybe it sticks around, like you got achy knees for a week because the volume was way high on your squats. But, after a couple weeks that completely went away and you just had to warm up really well, and then that was that. Or is it get worse as the volume goes on? Doesn't matter if you warm up, but as you do more and more sets, the pain gets worse instead of it getting better. Obviously that's big, but some people just kind of think that you always have to push through. And if your body's telling you something, then sometimes you gotta listen to it. But I would say if an ache or pain is gone after the warm up, then we can start to explore the option of pushing through and maybe say that's maybe the normal part of this training process. If a pain seems to be getting worse, the more reps you do, that's probably something we need to back off a little bit. The nature of the pain, is it start at one location, let's say in your back, and then it radiates up or down? That's probably a little bit more serious in nature than something that's more localized, that you can really pinpoint and it's consistent. If pain is radiating, that's kind of a umbrella alarm sound from your nervous system. Now you got kind of the whole system freaking out a little bit, and as a practitioner, it's much harder for me to pinpoint what is injured and what the actual problem is when somebody is that flared up. And so if over the course of training days, if the pain was pinpoint, very local to a specific area, and then over the course of days or weeks, it's now broadened to a larger area, that's something that we should, probably look into. Something is going numb, tingling, all the neurological type things, searing, stabbing, shooting pain, very abrupt, acute sensations, you should probably respect. General achiness of a joint that I said again goes away the more you move around. If you got to take a few extra warm-up sets, you're probably okay in that respect. And I'm sure there will be a lot more examples that we can go through as we go on.
For sure.
Just to branch off that a little bit, are there any kind of guidelines that you would recommend for a coach and athlete when determining if a situation is something that you can work around or it's something that you need to seek external help? So let's say if there's an athlete that's feeling apprehensive about a movement and maybe starting to experience a small amount of pain on the 1 to 10 pain scale, when do you know if it's something that you can work around or when you need to seek the help of a practitioner?
Yeah, these are all tough questions because it's so context specific. I think that if you are modifying the movement and it's not changing, I think a big guideline is the pain is not changing for the better, no matter what you do. And so if it's a back squat, and we could pick a body part, but if it's low back pain with a back squat and you've tried front squats, you've tried safety squat bar, you've tried belt squats, and you can't find a variation that changes the pain for the better, you should probably refer out, because as a coach you're running out of options. And the more that you try, the longer the athlete's in pain, the more it then kind of becomes associated with you. And so you don't want to punt everybody who's got pain. A healthcare professional may tell you, well, anytime somebody has pain, you should refer out. But I think if you're unable to find variations over the course of 1, 2, 3 weeks that the athlete can do with at least less discomfort, and it also doesn't flare them up after the training, then you need to refer out. I think that, and then that last point, the pain shouldn't get worse. And I touched on that during the training. As sets go on, they shouldn't be in more pain, but also afterwards. Mm-hmm. It's pretty much the same thing. Like if you feel great during training and then that evening you're always you can barely move because now the pain is flared up, or the next morning, it's the same thing. You've pushed it past your tissues or your body's capacity, and now you'd probably have to take a day or two for that to die down before you can do it again. And it's just like this vicious cycle. You take a step forward and you take 2 back. So I think if you can't modify the pain, if you can't change it, even going to, now I got to do split squats or some type of whatever, single leg RDL, something that's easier and it still doesn't help, then you should probably get it checked out. If it's lingering for 3 or 4 weeks and there's no change in status, you should probably get that checked out. It doesn't mean it has to be cured. There just need to be some trending change. And it's obviously, if the issues are getting worse and worse over the course of weeks, you should get that checked out. But it's got to be, it can't be necessarily a day-to-day thing unless there's numbness. My foot's numb. I've never felt this before. I felt something go in my back and now my foot's numb. That's something that should probably go right away, and get that checked out. Or I benched, I felt a tear, like these obvious acute injuries.
Right.
But just from a day to day, you've got to look at trends. So have a plan B, have a modification, a variation of the movement in question, and try to change the symptoms for the better with those variations.
Can you talk a little about some of the chronic stuff that athletes might be going through? I mean, for powerlifters specifically, there's a lot of kind of recurring low back, hip stuff, and then kind of tendonitis in shoulders and elbows. Besides coming up with effective training and finding ways to modify it, are there any things that you found that have helped?
Well, I mean, you say besides effective training and modifying movement, there's nothing that's really more effective than that.
Let me take effective training off the table. Modifying movement is well within your wheelhouse.
Yeah, well, I think a lot of these. So if you want to think about tissue damage or like initial injuries, tendinopathies, tendinitis, all this stuff, like these general umbrella, sometimes garbage terms because we can't think of anything more specific. It's just like, oh, knee pain, tendinopathy. You got to think first off of capacity that's less than load. There was a dose that was past the tissue's capacity to adapt, recover, and cope and progress. And so then you had breakdown. Instead of build up, you had breakdown. And so I can never have a conversation about these injuries without talking about the training dose. It's just not possible. There's a reason that the injury is occurring, and it has everything to do with the training. And so that's a difficult conversation to have because everybody's a little different and we've all got our egos. But in general, modifying the movement can come in several forms. So it doesn't necessarily have to mean changing the movement itself. Like if it's a bench press, it doesn't mean we can't bench, but some variable has to change. And when we talk about tendinopathy and tendinitis and chronic wear and tear stuff, a lot of times it's the tempo that we modify, because what the literature is showing is not, and people have become pretty savvy to this, like eccentrics are great for tendon loading and that type of deal. But what the evidence is showing now that it doesn't have to be the eccentric portion of the lift. It can be the concentric. It just needs to be a little slower. And the tension needs to be constant through a set. So one remedy that we give for pain in the patellar tendon or elbow pain or pec pain is tempoed versions of the lifts. 5-second descent, 5-second ascent, both sides of the range. It's termed in the literature now heavy slow resistance training. This is now a scientific term because what we know about tendon loading is that it needs that time under tension to remodel. The fast reps, the explosive, even for powerlifters who move slow as hell compared to weightlifters, it's still fast and it's still cyclical. And that's the biggest thing with these wear and tear, chronic overuse type injuries is the cyclical loading. It's the same movement. It's the same pattern, which can be fine as long as the dose is always under capacity. But we have to push that a little bit. And so if we can get rid of the cyclical fashion in a sense of slowing down the tempo, now the tendons are going to be loaded mechanically in a way that they were not before. Whereas before they were almost just being stressed. They were being used to distribute forces, and now they're being used to support the load. So again, tempo is one thing that we do. Isometrics, decreasing the range in certain positions. I call it, I use my hand a lot when I'm talking about these. Let's say, this is the ceiling of your capacity. If it's a squat, maybe it's a certain percentage that only hurts, and then my response is, well, you're just not strong enough. So get your work done at lighter percentages and build your volume there. Or maybe it's a certain range of motion. Regardless, let's say you squat at 90%, you feel back pain. Well, so that's 90% smack. I feel my symptoms. You've got to build your volume at 80, 85, 70, whatever. You got to touch the ceiling, but you can't slam right into it. And eventually what's going to happen is that your capacity will rise. And that's just training in general. But I think that chronic stuff is there because people don't respect that it's a signal that something needs to be modified. And so that can be volume, but we like to use tempos. We use shortened ranges at times. Isometrics just short of the painful range of motion. So you move as deep as you can, as low as you can on the bench, as deep as you can on the squat. On the pull, we'll raise the bar up just high enough off the floor before maybe your pain is off the floor. Maybe, we raise it up 2 inches, and so it's just short. And then maybe we do like an isometric hold where you break the bar an inch off the floor and you hold it. So we're strengthening you there. But I think we've got to think less about what's wrong. When people are injured, think less about, well, what's wrong with their tissues, and think more about, well, what's wrong with the dose. And I don't even know if that answers your question, but that's kind of the general approach that I take. It's much more of a strength coach lens, but it's with tissue adaptation principles in mind.
Yeah, no, I love that. And one of the things I think that we're all kind of taking for granted because we're all on the same page here is that we're trying to modify movement to keep the athlete progressing towards their goals. We're not trying to stop all movement and say, sorry, stay home, stay out of the gym, time to rest. And that it's really about kind of keeping them progressing toward their goal in some fashion.
Well, a big problem is, if you go to a physician or something, I don't want to single out physicians, but a lot of healthcare professionals just like, all right, just take 2 weeks off and, come back and we'll see what's what. And there's problems with that. And one of the big problems is you become deconditioned. And so taking time off is kind of a no-brainer in the sense of, well, let's not keep just jamming you into the pain, like we have to turn the engine off for the mechanic to fix it type of deal. But if you just take time completely off, then you become deconditioned. And why, if you're injured now, would you expect to become unfit and then go right back to the things that were hurting 2 weeks ago and have it not hurt? It just doesn't make any sense. And then, okay, well, I'll take a month off. Well, now you're twice as deconditioned, and so it's like the inflammatory process will go down, the sensitization process will go down, like the nervous system will calm down, and all of that's great. But in the meantime, you have to be doing things that are maintaining as much fitness as possible, or else you're just going to have this cyclical event of like, I take time off, I feel better, then I blast myself again and I hurt, and then it's a year later and you're thinking that something's wrong with you. And I get that all the time. I just have a really bad back. No, you had a really shitty rehab. And so it's like, I think you're right. I think people take that for granted and they don't quite. And, Hani, back to your question about what to look for, how did PT school broaden my scope? And I think it's been that, taking training principles, but also knowing what's okay to push and what's not comes with experience. Because when I was very, very young, and I'm still a very, very young physical therapist, but like in the very early days, I didn't know what was too much. I knew you were injured, but I honestly had no idea because every injury was new to me. I didn't know how you would respond to like pushing things a little bit. And that just comes with experience now. And I have a much better idea of what is going, what you need to rest and how much you need to push through to maintain, as much fitness as possible. But in general, complete time off, a lot of times doesn't work, especially in chronic situations. In acute situations where there's a true inflammatory process, there's swelling, it's a new injury. Complete time off, complete rest is much more backed by evidence than chronic issues that don't necessarily associate with inflammation or even structural damage. A lot of that stuff is there's a psychological component to that. There's a neural component, and I'll get a lot of people say, yeah, I mean, my knees actually feel better. Like my tendonitis in my knees feel better when I train, and when I take time off, like I just feel more achy, and that's what makes this thing so variable.
Totally. And, it's super self-explanatory, and this is something that I've heard you say before, and I was actually going to reference the analogy you were making about kind of the rooftop of pain, right? And so it's, you have this movement that hurts, and it's like the more of this movement you can do without it hurting, the more you're going to be able to do without it hurting. And it seems super self-explanatory, but it's just a super practical approach to getting back from injury. Ultimately, if you can't do this, but you find a way to do this, use that way to get back to doing it the right way. And, this kind of circles us back around. It's, if, for, let's say me or for someone watching this, it's how do I know that I have what is actually an injury instead of something that's just like an unusual ache? Because once in a while, you'll just have a day where you go into the gym and you just, quite frankly, you kind of feel like shit. And we've all experienced that, where you go in and it just sucks. And, you kind of do whatever it is, you roll out, you stretch or whatever it may be that you're going to do that makes you feel better in the moment at that small piece of time. But how do I tell when that's something more? I mean, what is the immediate sign for that?
It depends. That's going to be my answer for everything that you asked. By the way.
Sound like Eric. You sound like Eric Helms.
Yeah. What was your? Well, tell me, Hani. When you hurt your shoulder, what was the difference between that and just an achy shoulder that you can push through?
This is a great example, actually, now that I think about it, because so I was playing around with some kind of experimental training methods leading into my last meet, particularly for the bench press, maxing out my bench press 3 times weekly, and truly a max between like an RPE 9.5 and 10, 3 days a week, with some volume backed up off that, which is a very
is that
intense
the
training
Bulgarian bench program?
No, it's no. It's it is, it's highly effective, but you have to be incredibly injury resilient and have perfect technique. And I started to have breakdown towards the end of it. But the reasoning behind it aside, more or less about 3 weeks before my meet, I started to feel a little bit of an ache in my shoulder while I was training, and it was just a dull ache when it first started. And I thought to myself, the typical barbell athlete thought, who's, not really thinking in the broad scope. I thought, oh, I'll just get some ART on my shoulder, I'll be fine. And so 2 weeks later, it gets to a point where it's actually starting to cause my bench press to hit lesser weights, where I was expecting to hit something like a 396 or a 402, I'm finishing in the 370s, and it's just too painful for me to go up. And so I go see my chiropractor, and he does, he kind of moves my arms in directions, puts his thumb in some places, and he says, you're good to go. And so I come back, and that was a week out from my meet. Mistake number one for me. But then the following day, I go in and try to max my bench press again, just jumping right back into it, and damn, it hurt. And I mean, that was the point at which I knew I was injured. And I mean, in my case specifically, it had been something like 13 months since I'd last competed. So it was like, I didn't care. I wasn't going to not do the meet. And I didn't know what to do, because this is such a radical training protocol that I felt like to take a big break from it, as in to go from maxing your bench press every day to suddenly, training with 60% because it hurts. In my mind, from a programming standpoint, I thought, no, I can't mess up the system like that. I've put this much into it. I've hit 27 maxes in a row. I'm not going to stop before 30. And so that Monday I went in and did it. That Wednesday was actually a taper without a max, and then the meet was on Saturday. And I felt like crap on Monday. I felt like absolute crap on Wednesday. I got to the meet, and I ended up having to lower my entire plan by 10 kilos, opener, second, and third attempt. And basically it was on meet day when I did my third attempt, and it was weight that I should be able to triple, and it moved like I was pushing it through molasses, that I was like, I think it's time to go see Quinn. And, it was a little bit too little too late, right? Or it was actually a lot too little too late. It turned into what ended up being a pretty reasonably severe rotator cuff strain that I am still working through now. But at the time, if I had been a little bit more forward thinking, or maybe had a little bit more information in my mind, I probably could have taken a more informed approach and either done better at the meet, or more importantly, not had to suffer through what has been now like 11 weeks of just crap upper body training. Like, no offense to what you're recommending to me for rehab, Quinn, but it's just, obviously that's the best I can do. And that's what I can expect from you, is to give me prescription for the best that I can handle. But I would much rather be bench pressing full range of motion with appropriate work percentage weights than playing around with bottom up kettlebells and using board presses. I cringe every time I see myself do a board press. But anyway, so that's what my process was.
Well, and I think you answered the question with a lot of things right there. And I would say that it was a perfect example of load greater than capacity, just dosing, right? I mean, it was a new program, maxing out you're rolling the dice there, and you know that. You said it's a program that people they have to be resilient and injury proof, and you've got to really dial in your nutrition, I'm sure, and make sure you're getting sleep and recover that way to be able to handle something like that. And you handled it for a long time until your tissues couldn't handle it anymore, and then that's what happened. And you just try to maintain as much as possible. Very, very common scenario. And then it turns into picking up the pieces, afterwards, which you're doing now very well. And a month from now, you'll probably be back. But to your question is like, how did I know? Well, that when you first started getting achy there, that's where it's hard to tell, And I think it's a yellow flag. A red flag is something that makes you stop and right away maybe you refer. A yellow flag is something that you just need to take pause. Take caution towards, and just having a new ache at the end of a cycle, where you've been hammering things pretty good, and you've been feeling good, and then all of a sudden, intensities are at their highest right now, and then you're getting a new pain. That's something that you just need to be cognizant of, which you were. But then the factors were it didn't get better, and in fact, it got worse. And every time you try to touch the bar again, it was worse than it was the previous session. And then it started to affect your performance. You literally couldn't lift as much. And so now you have this inhibitory weakness. You've got muscle, I think at that moment, had you not had a meet, I mean, you knew something was going on. You just had to do the, I get that. But that's when I think that you can know that over subsequent sessions, the pain has gotten worse each time, and now it's affecting my performance. There was probably some apprehension there too. Like those last few bench workouts, you're probably walking in knowing, oh, my shoulder's going to really feel like shit on this one. And like, that's not a good place to be. And I think that's when you start expecting pain, when you start planning like a plan B because your shoulders may hurt, like those are the types of signs that let you know you're probably injured. There are other times that I'm sure all of you can attest to where you started to get a new ache and you just had to do a few more warm-up sets, or maybe it didn't necessarily get better over like a week or two, but it didn't get any worse. Your performance wasn't affected, and then maybe it just resolved itself. Or you were doing some extra like band pull-aparts or some shit, just to get some blood flow in there, and that made it feel better, and then it just eventually went away. Or you maybe you get the same work done from those practitioners, and you felt like that helped. But in this case, there is nothing that's going to magically fix a rotator cuff sprain, and there are many. The rotator cuff, in particular, is a very, very slow healer. It's the blood supply is horribly bad. It's just not a good place to have what you had. And I think had you not had the meet, we would have jumped on it way sooner and dialed you back. But that's just kind of the way it is. Yeah, just got to look at trends though. You got to look. You got to take 2 and 3 week blocks at a time and say, is it getting better? Is it affecting my performance? And then sometimes, is it affecting my daily life?
Yeah.
Reaching for something. That now my shoulder hurts. These are all signs that you should, take caution to these things.
So at this point, I would say a fair summary of kind of what we went through there is I should probably see someone about this if it's starting to affect my performance.
Oh, totally.
That's like a good point to where you
consistently affecting your performance. Yeah.
Right. Yeah. If you go in one day and you feel crappy that day and it affects your performance, but then your next training session, you're totally back to normal. Obviously that was just kind of focused on that one day. But if you're progressively getting worse, if I go into the gym and I'm like, ugh, I don't want to bench, this is going to hurt, but I'm going to do it anyway, I should probably see someone about it.
It's not a bad idea.
Yeah. Okay.
I wanted to ask you about something that Hani mentioned in his kind of synopsis of his bench. He was talking about how he went to someone for some ART work. He got some ART work and then was like, bing, bang, boom, I'm good. I'm back to training. How should people engage with physical therapists and people? How often should they do that? And like, is it like an oil change? Like, because I think a lot of people think of it like an oil change where you just go in, you get a treatment one time and you're good and you're back to normal. Is regular maintenance something important? What's the role of physical therapy for strength athletes?
Well, so we have to define what your definition of physical therapy is, because it sounds like to me the way that physical therapy is being defined as is going in and getting some type of hands-on treatment, and that's just happens to be the choice of that particular practitioner.
Sure.
And so it just depends. Physical therapy is just a profession. Chiropractic is just the name of the license. I as a physical therapist can do manipulation. People would think of that as chiropractic, but the intervention of a joint manipulation can be done by various professionals. Soft tissue work. It's all kind of the choice of the provider. So when you say maintenance, I think that we have to first talk about the mechanisms of these things. I think we've got to back up a couple steps and talk about things like ART and just manual therapy in general and what they actually do. Then we can talk about whether it matters or
Sure.
if that's something that you should think about.
So we'll revisit this after we kind of talk about some types of therapy. Sure.
Okay. So you want to talk about that now?
Yeah.
Okay.
I
All
just-
right.
Wait, is
I think Eric
want
had
to
one
change
more
this to a
question.
different direction? Yeah. Go ahead, Eric.
I just
Eric
had
one more thing.
I had
yeah.
one more question on the chronic side of things before we move on.
Okay.
So Do you find it's most common when someone comes to you with a chronic issue that it's from the training dose itself, or would it maybe come from their movement quality or structural limitations or something like that?
It can definitely be a diagram of all three and many other factors. Movement quality is an interesting conversation because I don't actually know what it means. There's no gold standard. There's no right or wrong necessarily, because you all have seen people who squat in many different ways, people who prefer different deadlift positions. There's obviously some universals. I mean, maybe, if you're in a question mark back position, it's going to be harder to pull, but movement quality is such a nebulous term. You can move however you want to move, and you won't feel pain until the dose increases the capacity of your tissues. Now, certain positions may lend itself to where they're not as robust or leveraged, so that maybe they can't handle as much load, and so that's where we get into movement quality. So yes, from a physics standpoint, you want to leverage your body so that your joints are stacked, your trunk is relatively rigid, and your hips, knees, and ankles and shoulders and elbows can all just hinge naturally. But I can't define movement quality. I don't know what's good or bad. And so I change movement based on the individual in the moment. So if we always modify dose, we always have to do that, because if they're in a pain state and they can't handle the current volume, we have to modify dose. But yes, I may change movement. I may work for a different tilt of the pelvis. I may put the feet in a different position, elbows. It doesn't mean that the prior position was bad. It just means that the prior position has been worn out, for lack of a better way to describe it. It was a chronic cyclical pattern that created sensitization in the tissues, potentially some damage, and we need to change movement to distribute forces in another way. But to say like movement quality, it's just tough. I think I know what you're saying, but I just can't say that if somebody's a poor mover. First of all, I can't define poor, and I also can't say that they're going to be in pain, because it just doesn't always work out like that.
Right.
So it's a combination. It's a combination of all those things.
That's definitely a good point. I'm sure we all know plenty of people who have just god-awful technique, and they somehow manage to train uninjured while we're over here struggling to have picture-perfect bench presses and squats with all sorts of pain.
And I think then the argument's always like, well, yeah, they're not injured yet. And I get that. I really do. I think that if you, as a coach, like you guys know how to coach the technique to a point, and if you, from a physics standpoint, if you're stacking the joints that creates the best leverage to move the weight, it's usually biomechanically sound. And so if we can define that as just general movement quality, then yes. If somebody's knee is 6 inches inside their foot, and that's where they're trying to drive, from a valgus standpoint, that's where they're trying to drive into the ground. Well, I can just say you're just not going to be able to push into the ground and produce as much force. I don't even have to go down the injury route when I'm teaching it to that client. I'm just like, you're not going to be able to lift as much typically just from a physics standpoint that way. And so I quote unquote fixed the fault regardless. My cue was the same. I just spun it from a performance perspective and didn't, put some fear-mongering thoughts into their head, because that's where the movement quality conversation goes a lot of times, is like, this is bad, you're going to get hurt, and then people start, it's almost like a nocebo effect, if you guys have ever heard of that. It's like something that would have not been a problem, but somebody planted a seed and now it's a problem. Mm-hmm. Like somebody comes into my clinic and they've never had knee pain in their entire life, and I say, oh, you squat like that? God, your knees are going to blow up. And then 2 weeks later, they're like, you know what? You were right. I've been thinking about that, and now my knee hurts. And then, like, as a practitioner, maybe I'm like, oh, sweet, I scored. Good business move. But no, like we see that a lot. That nocebo effect, and it comes with like the back too, the spine. Never flex your spine. You should hip hinge if you have to tie your shoe. And there's some things that are just they're not backed by the pain science research that we're seeing, and so it's a whole different can of worms with this. Like what's good and bad as far as movement. But yeah, I think it's a combination. It's dose, it's changing movement to some extent to take out, the exacerbation, at least for the short term, and go from there.
This is a fun time for us to transition, actually. Speaking of nocebo, that relates to placebo, and this is a great way for us to talk about all the different kinds of therapy we like.
You mean all the different types of placebos?
Yeah. So this is a very common argument between Bryce and I, and I've vented to you about this, Quinn, on a couple of occasions, and it's I have more of a pragmatic mental take on it, and it's like, if you want to wave your hands above me before I train, and somehow in my mind that makes my knees feel better before I squat, wave your goddamn hands above me. I don't care. But for kind of, it seems to me, Bryce's take is a little more, he's like, show me the evidence, show me that it works, and I will buy into it. And I can totally see arguments for both sides, right? And I want to be the pragmatist. I also want to be kind of the scientist when it comes to the approach here. So there's a few, we want to ask specifically about a few different kinds of therapy. And we can start with, obviously one that's near and dear to your heart, physical therapy and physical therapists. So from what a physical therapist is going to learn going to receive their DPT, obviously a lot of what you do on a daily basis has very little to do with that. And I've had this conversation with you before. It's a lot of practical experience, what you taught yourself about kind of active release technique, the brand of that particular type of tissue manipulation, and how you've kind of learned all these things as you've gone on, and they're not, or PRI, for example, these aren't things that they teach you going to physical therapy school. But let's say that, this happened to me when I first kind of dealt with the tendonitis in my left knee. I went to just a physical therapist that my doctor referred me out to, and it was just a Corey and Bueller, which I'm sure you're familiar with. They're a giant practice down here in Southern California, and basically I saw this person, and without me even telling you what they had me do, you're like, oh, they probably had you do clamshells and some kind of glute bridge, and slapped you on the butt and said, have a good day. And that's exactly what they did. And that's probably what applies to general population. But you can look at me standing in a pair of shorts and you can figure out I don't have lagging glutes. This is a very obvious thing about me. And so generally speaking, with regards to physical therapists, would you say that we should have some caution with, or just, should we challenge anything that they're going to have us do when it comes to things like dry needling, for example, or different types of massage?
You should always take caution. So I'll back up and say physical therapy is the name of my license. My doctorate is in physical therapy, but the term physical therapy can mean so many different things. It's literally whatever you got when you walked into a physical therapist's office, whatever treatment they did was physical therapy. The problem, and this is a problem with the profession, is that if you when had knee pain, you went into a physical therapist's office, if you went into 10 different offices, I guarantee you would get 10 different opinions and you would get 10 different treatment plans. And that is the problem right now with the profession. There's no standard operating procedure. There's no base of science that they work off of. It's all, every school is teaching kind of different biased systems, and it's all kind of, they need to all have the same core curriculum to an extent, but it's just so much variance, and that's one of the problems. So, just as an aside, you come to me as a physical therapist, now physical therapy means something very different if you go somewhere else. And I get it all the time where people say, oh, physical therapy just didn't work for me. And it's like, no, you didn't. That particular physical therapist didn't work for you. It's like, you don't go to a physician and not like that MD and say, well, doctoring just doesn't work for me. I guess I'll just die. You just go to another doctor, right? And so it's like that. Now, as far as these different schools of thought, so these, I'm just going to blast a bunch of them. Not blast them, but just list. ART, active release technique, trademark. I need to say trademark or I'll probably get sued. So that's a registered company. That's a brand. Graston is another one. If somebody has a metal tool and they scrape your skin and they say they're doing Graston, that's like drinking a soda and just every soda you drink is saying Coke. Graston is a brand. Instrument assisted soft tissue mobilization is the name of that type of intervention. ART is just a brand, so it's really just soft tissue work. It's active, it's mobilization with movement, I guess. Stick your thumb here and then move the limb that's in question. And so we won't even talk about these brands, but instrument assisted soft tissue, dry needling, cupping, so all of these different modalities. Hani, you mentioned that you don't give a shit what works as long as it works. Correct. You said that. You said it. We're on the tape. You said
basically, more or less.
The problem the problem with this is that, let's say on my table, on my treatment table, I have a cup, I have my cupping set, I have my dry needling set, I have my garden tools or my instrument-assisted soft tissue mobilization set, I have my hands, and I have any other thing in between that you can think of that are, these types of treatments. What we don't know is the difference in the physiological mechanism of any of these things. And so if they all have potential to take away your symptoms, how do I know if it's going to work or not? How do I know which one to pick? The problem right now is that I don't, because these mechanisms they don't seem to be structural in nature. And so when I scrape your skin with a metal tool, if I take my thumb and I go over the line of the fibers of the muscle while you're moving your arm, if I stick a needle in you and then put a little electrode in there and get a twitch, no matter what I do, what the research is showing, or at least what it's showing that these things are not doing, is breaking up the collagen fibers, like literally changing the structure of your physiology in that moment. And thank God, by the way, that we're not that fragile. Or if you think about it, the barbell would disintegrate us if it was sitting on our back and we were made of clay that way. And so it's very much so a neurophysiological response. Many people would say that is that's a synonym to a placebo. I'm not sure yet if neurophysiological response and placebo are the exact same thing, because a neurophysiological response is still physiological response. What I mean by neurophysiological response is that these implements are sending some type of sensory input that's inhibiting the pain response somehow. So an example or a context here. If I like a basketball, I jam my finger. You guys ever jammed your finger with a ball and then you shake it just intuitively? You're like, shit. Or you stub your toe and you like hop around and you stomp. That's a similar mechanism. You are creating another sensory input to override the immediate sensory input, output, which is pain. Input to override an output. Pain is a conscious perception. It's a conscious output. And that's the problem, is because we can't differentiate the mechanisms of these different modalities, it's very, very hard to then differentiate the assessment. Why would I need to use my cup as opposed to a dry needle? Why would I need to use my thumbs versus the tool? Those are the questions we don't know. And so what it turns into is whatever course you took, whatever you decided to take, is now your tool of choice. There is no unbiased, like I just happened to go to an instrument-assisted soft tissue course and now that's what I do on everyone. When, Dr. Jim, physical therapist over here, decided to go to a spinal manipulation course, and then that's what he does on everyone. And so I just don't, because I can't explain the mechanisms very well, and I don't want to spend $40,000 to go to all of the courses and have all of the, make sure I'm covering my butt using these types of tools, then I just don't. And it becomes pretty simple. I think like the thumbs, ART, it's the same. I think that there are some sensory inputs that are probably stronger than others. Like if I stick a needle in you and I get a twitch response with electrodes, that's a little bit more invasive than my thumb. So maybe that creates a stronger neurological impulse, but I can't prove that. There's no evidence to say that. And I also think, and I don't think this, I know this is pretty well established, that patients' expectations are about as powerful as any other treatment that I'm going to give. And so if somebody walks in my door and they are expecting dry needling and I don't give them dry needling, there's a very good chance that whatever I do give them is not going to have the same effect as if somebody coming in and wanting me to coach their movement to get rid of their pain. And so past experiences, patient, and I ask these things too. I say, what type of treatment have you gotten in the past? Did it work? Why didn't it work? Did you like it? What are you expecting in here? These questions are extremely important because if somebody's kind of already established what they feel is therapy to them, then I need to be careful with my words, and we need to have conversations rather than just saying, it's what you were getting in the past was bullshit. Because now we're messing with things a little bit. And I know I'm jumping around, but I'm gonna stop there. You guys probably have some follow-up questions,
well,
and we can like back together.
Quinn, you just mentioned something kind of interesting. I've been doing some reading on psychology, and I'm wondering if you feel like you might be able to prime someone for a specific response by, let's say they're lying down, face down on your table, and you're like, oh wow, like this is really knotted here, and oh man, I just released the shit out of that. How does that feel? Do you think like you can kind of prime them and be like, oh wow, actually that feels better, and maybe there's some actual physiological response as a result?
So the first part of your question, can you prime them? You absolutely can. You can bias the hell out of people. You can nocebo, you can placebo, you can really, really manipulate their expectations by the way that you talk, the way that you touch them. So absolutely, this is shown. They would call that non-specific effects. So the way that I put my hands on you, just the fact they've done sham studies where one group does manipulation, like trained manipulation, something they teach in courses, to the neck or something like that. One group is control, they get absolutely nothing, and then the second group gets a sham treatment where somebody just like moves them or they just like touch them, and then outcomes are very similar. And so it's like the touch. It's the expectation that you're being touched by a professional, like that can be very, very powerful. And that's not in all cases. I know I'm gonna get burned at the stake with all the stuff that I'm saying. It's just the truth. But yes, you can absolutely bias expectations. The second thing you said, can that create a physiological response? If by physiological response you mean neurophysiological response, the person changes their perception, yes, absolutely. It's not going to have anything to do with being able to change the structure any more than it already could, which it typically can't.
Got it.
There's a interesting study. They had to do a 3D mathematical analysis because you couldn't put 2,000 pounds of load on somebody's tissues, but essentially, like a fascia of the leg, like the tensor fascia lata, the deep fascia of the thigh, needed upwards of 2,000 newtons of force to create a 1% shear in the tissue. I mean, like astronomical numbers. The fascia of the nose, beyond or very, very close to physiological limits to create a 4% shear. And so basically the point is to think that we can break up underlying levels of tissue without ripping the skin apart just doesn't make any sense. Like, how can I break up the scar tissue underneath your skin without ripping through your skin? And so there's some premises that have just not been validated, but they've been kind of taken as fact because they're from the practitioners who have been doing it for 30 years. The kind of guruism that you see with these systems, and you have to take pause because there's an agenda behind that. And there's one question I think you guys asked was the difference, or maybe you didn't ask, but it was in my head, the difference between acupuncture and dry needling. I'm probably the wrong person to ask because I would say that the difference is nil. It's a neurophysiological phenomenon. An acupuncturist would say, perhaps, I'm not trained in either discipline, but they would say that no, that I'm basing this off of certain meridians that are more universal in nature, and a physical therapist performing dry needling would say that no, I'm sticking the needles based on mechanical disruption. A trigger point, which by the way is a premise that's not been validated. We're finding this trigger point. It's where you hurt. It's where the joint doesn't move. That's where I'm sticking the needle. It has nothing to do with meridians, and that may very well be the case. There's no evidence to say that the mechanism is any different. And there are studies that show like the needle points are it's like 90% overlap. So it's pretty much the same anyway. And they've done toothpick studies with poke people with toothpicks again, and that creates a response. And that's how strong patient expectation and placebo can be.
Do you think?
Go ahead.
Sorry. Do you think one of the reasons that it's so difficult to standardize the treatment protocols is that the patient's psychological bias is easily influenced?
Yeah, it can. It's hard to control for that, and that's the knock on a lot of the science too. And that's just because there's not evidence or I haven't seen the evidence, that does not mean there's absence of evidence. And so the things that I'm saying now are just based on what I have seen, as far as the research. There could be something where they control. I know a lot of the studies on manipulation, the chiropractic community hates those studies because they feel that the parameters aren't very controlled. The measurements are off. They're not standardized at all, and so it makes the chiropractic adjustment look, ineffective or very non-specific. And then, to your point, controlling the psyche of the patient. I mean, gosh, that would be awesome. That would be huge, and I think it would make total sense. And that would be a way to help my assessment. I'm going to pick this intervention based on your past experiences, based on your personality breakdown, that type of deal. I think that would be very, very valuable. I'm not aware of any comprehensive literature on that. This type of personality will respond to this intervention, but yeah, that's a variable that should be in there.
It's got to be difficult to create quantifiable research when usually the outcome that you're looking for is just, hey, I feel better, rather than with powerlifting training or any kind of strength training in general. You're looking for an actual number increase for progress.
It is, and there are lots of studies, again, manipulation, dry needling, cupping. There's a lot of research that shows the outcome measure is just people's perception, subjective report of pain, and the pain got better. Like, there's a ton of literature on that. And that's a practitioner who has invested their career in these modalities, that's the type of evidence that they will cite. Is like, people get better. And then somebody like me, who's not invested necessarily in one system, will say, yeah, but look at all the other systems that got better. And then my argument is like, which one, if they can all work, does it even matter? And that's why I have a hard time having all these quote unquote tools in my toolbox, because I haven't found the right use of each tool. It seems like all of the tools fix the same thing, and I don't have a very good way of explaining that to my patient. And so when they inevitably ask, so what does this needle do, or what does it do when you crack my neck? I'm either going to lie and say, oh, I broke up this or that, or I readjust, or I repositioned this, and now it was out of place, and now it's put back in, or I'm going to say, I don't know. And that's pretty much what I do. I say this is creating some type of sensory input, and then hopefully it'll knock down your pain so that we can go and load it, which is what I do with Hani. We worked on, we did some, he had an acute thing in his shoulder, and I, did some things, and then range of motion, short-term improvement in range of motion, and then we went out to the gym and we figured out what we were going to be able to train. So yeah, and then some people I probably would have skipped the manual therapy part.
So coming back around here, of what we've talked about so far, obviously we're just talking about subdivisions of what physical therapists would be doing. Would you say that there's any of those that are just a total waste of time?
All those systems.
Yeah.
You mentioned like all the things that I mentioned.
Like instrument assisted tissue manipulation, and dry needling, and whatever the non-specific term for ART is, and
yeah.
And so would you say that obviously there's you kind of have to draw a line between pragmatism and shamanism, and so it's like, where do we, where do you feel that line should be drawn?
I think so. I've got colleagues that I know, if they were listening right now, they would be in my ear and they would just say it's all bullshit. Just say it. Say it's all. So, but typically what I do is I can't ignore all the evidence that I mentioned that these things can feel better. I think that versus a control versus another system, there's not a ton of difference. I have not seen really any difference. And so you could say that it doesn't matter which one you do, just do one of them. And it's almost like a trial and error. If the patient doesn't like that one, then try this one, and usually something will stick. But that exact reasoning is why I think that if none of these things existed and the only tools that physical therapists had was their ability to reason and rehab with exercise and movement and logic, then I think that we would be better off. So I can't pick one of those systems and say that one's a waste of time, because if I said it for one of them, I could say it for all of them. Mm-hmm. And that's just my opinion based on the evidence that I've seen.
That's fair. And I mean, I kind of expected that answer from you, because, you know, like I said, we've talked about this before, and for you, it was a lot about, you're like, if this, whatever this is going to make this person able to feel like they can go and train without pain, why would I not give them that? Mm-hmm. And so it's like, ultimately your job is to keep us moving the barbell. And I mean, obviously that's not a direct quote of what you said, but anyway.
So and it's also to educate. You know, I don't, there's some interesting research that even when you tell somebody that they're taking a placebo, it still works. It's crazy. Like, the mind is insane. But that's why now I'll still be honest about these mechanisms. And, you know, I'll talk about these things, these systems. Like, we can't even dry needle in California, so it doesn't matter. I don't do cupping. I don't have the metal tools. And I just, sometimes I'll use my hands, and I'll you know, mobilize a joint to have some type of sensory inhibition there. But that's pretty much the extent of my sessions in general. 3 to 5% of my patient care comprises of that, maybe. But I'm just honest about the mechanisms, and I think that's the biggest thing. I think can be evidence-based practice. If you say, I'm doing these things to send some type of neurosensory input to you, and then we're going to go and load these tissues, I think I'm okay with that. Mm-hmm. I'm not okay with making up things like this is doing something that it's not, type of idea. But yeah.
So that actually is a good segue for us. I think we've touched on enough about physical therapists specifically here. Okay. Kind of delving into chiropractors a little bit more. This is where kind of we get into that area where, you know, what they say they're doing, like you have a rib popped out from beneath the facet in your spine. I'm going to go ahead and set you on face down on this table, and when the table drops, I'm going to press down on your back, or I'm going to do, you know, a rotating spine manipulation or this and that, and it's going to put your rib back where it goes. So from a physical standpoint, what's actually happening? I had a lengthy conversation with Rory Alter about this, one of the clinical athlete physical therapists, and you know, the best way she could describe it to me was that basically it's not so much that it's moving. It's again a neurophysiological response, which is what you're getting at. It's just kind of, I mean, which I don't really have a full comprehension of it, so I'm hoping that you can enlighten
me either. Okay. So and I don't want to draw this into a line in the sand between PTs and chiropractors, because again, manipulation, spinal mobilization, joint mobilization is just an intervention that's used by many different types of licensed professionals. And so, again, chiropractic just happens to be an umbrella term for a license. Now, they have gone to school for 4 years for that specific discipline. And so they are much more trained in the art of manipulation, spinal or joint manipulation, than a physical therapist. The physical therapist would need to go to continuing training to get nearly as much as a chiropractor. And so the sense, I think, is that it's more specific. They're highly trained. It's more specific to a joint segment or a spinal segment. If you know, some chiropractors, again, I'm not a chiropractor, not trained the way that they are, but some will take X-rays and measure to the millimeter the position of the atlas or axis, you know, C2 on C1, and you know, track changes over time. And it's, you know, there's very little supportive evidence to say that these manipulations are specific at all. If you're trying to locate one spinal segment, you're probably moving 3 up and 3 down. You're moving tissues all over the place. I mean, you're moving everything. So the specificity of these certain things is very, very low. The rib thing is interesting, because I have many times somebody will come in the clinic and in an acute, like they just had a front squat and then maybe they ran it or something like that, and they're like, oh, they can't breathe because it's obviously some type of intercostal spasm. I think that's what it is when you talk about like ribs. It's not a rib that's popped out, because you wouldn't be able to just move Like that would be more serious. But I think it's some type of micro, because joints can move. We can sprain joints, so there's no reason to think that you can't sprain a rib or sprain a facet joint in your spine, because you absolutely can. I think it's the muscle guarding that you may feel as like a nociceptive input, and it turns into conscious perception of pain. That the action of that quick movement, I think that it perhaps moves some of the mechanoreceptors in the joint because it's so fast. You're seeing, you can see in imaging somebody like a hip mobilization, when you pull on somebody's hip really fast, you can kind of see it move, separate. The femur deproximates or distracts from the joint for a split second. It's so fast. And so one theory is that perhaps the mechanoreceptors in the joint sense that quick change, and it's almost like this neuroinhibitory reset that all of a sudden takes the inhibitory pain away, the threat response, the protective mechanism of that muscle spasm goes away. This is all theory. This is 100% all theory. In terms of the mechanism, the mechanism doesn't magically change if it's a physical therapist performing the manipulation versus a chiropractor. A lot of people would say that it does, but there's nothing to say that it does. It's no different. The more skilled you are, I think that maybe the less tries you have to get the cavitation. The cavitation is the pop. But even then, the research has shown that there doesn't have to be a cavitation to get the perceived benefit of less pain. So I'll kind of hang back on just talking about chiropractors specifically, because I don't have a chiro here to defend himself.
Sure.
But in general, I just don't see how the mechanism could be vastly different. Chiropractor, PT, osteopath. That's just me. That's coming from a less skilled PT. So those guys would probably say, "Hey, you little piss head, you don't even know what you're doing." And that could be totally true.
We'll see if we can have on some other guests too to talk about that.
That would be great. Yeah, that would be awesome. I would love that.
Quinn, we had some people write in some questions about recovery methods, just in terms of, not only on the physical therapy side, but just this other spectrum of things that people use to try to just throw every, piece that they can, so that they can just recover and get an edge on other people. So, you don't have to go into a whole bunch of the science if you don't feel comfortable, or don't have the expertise to talk about some of this stuff. That's absolutely fine. But different immersion techniques, so hot tub, cold tub, contrast, so hot and then cold, Epsom salt soaks, foam rolling, putting yourself in an ice tank. Where do you land on these?
I'm going to sound like a broken record probably. No, I think that there's so I'll just a couple of them. So foam rolling, there's some evidence to show that 10, 15 minute bouts of foam rolling, just general post training, has some type of inhibitory effect towards muscle soreness. So I've seen this in 2 or 3 where the groups who foam rolled were less sore 2-3 days after the hard training session than the group that did not. I've seen that with static stretching as well. And so then, is it because they did something and they think they did something and then it was a placebo? I have no idea. But when I prescribe foam rolling, or if somebody asks me when to do it, I say, if you're going to make love to the roller, do it after training or do it on off days, because there is some evidence to show that it can decrease perception of muscle soreness. I don't know why, but it can. Compression wear, compression garments, a similar conversation, can potentially decrease the fluid retention in certain areas too, and decrease the perception of achiness and soreness. Those types of things I prescribe for an athlete who maybe needs to go on a plane ride.
So
who will be
clarifying what you're talking about with compression stuff. Are we talking like, those big sleeves people put on their legs that fill up with water and just like squeeze the shit out of the muscle? Or are we talking
mean like Normatex?
Yeah, exactly.
Yeah. No, not necessarily.
Okay.
I'm talking like tight compression wear,
Got
like tight spandex, tight socks.
Got it.
Those types of things. So if you if you're going to be in a situation where you're going to be sitting for a long period of time or in a plane and fluids are going to pool, or maybe you're in a situation where you work all day and then you have to go straight to the gym, sometimes that compression gear can be useful because it keeps excessive fluids, extracellular fluids that just kind of pool in the legs and the feet. It keeps it at bay to some extent, and because that stuff can change your range of motion. If your ankles are swollen just with fluid retention, then it's hard to squat. You feel kind of achy, and so there is some evidence for that stuff. That there's actually some evidence that some of that compression gear can increase like jump performance, and we don't know. We think maybe it's some type of proprioceptive effect, like you just feel that tightness. We don't, maybe the fiber somehow adds some elastic quality. We don't know, but I think I prescribe that type of tight, like spandex socks, compression gear if somebody's going to go on a trip, but they need to like train right off the plane or something like that. Ice and heat are very benign to me. Ice especially I'm not seeing a ton of evidence to say that it has this crazy systemic effect, the way that, especially on the inflammatory system, the way that like an ibuprofen or some type of chemical anti-inflammatory would. Mm-hmm. There's this whole talk about, well, don't ice post-training because you'll quell the inflammatory process, and that's what we use to adapt. And I think we're giving cryotherapy, cryo chambers, local ice bath, I think we're giving it a little too much credit, honestly. My general recommendation is if you feel like ice helps you, if you feel like you're less sore or you're more ready to go by taking an ice bath after a very hard training session, then go for it. When it's somebody from an injury standpoint, I'm much more on the psychological side of things. If it's an athlete that I need to calm down a little bit, I tell them that they need to ice, because they are a confronter, meaning they keep jamming into stuff. I need them to feel like they're hurt. Like, this is kind of going down the rabbit hole a little bit. But if it's somebody who's like very fear avoidant and I'm trying to get them to ramp up, I don't prescribe many of these things, because that's the type of person that tends to be reliant from a psychological standpoint. And ice especially, like, oh, I got to ice after every time. I got to hit the cryo chamber every time I have a hard training session. If those weren't not in existence, I don't think we would be missing the boat on anything. That's cryotherapy specifically. The Normatec apparatuses, they're so expensive. It's just like some of the stuff is just so astronomically expensive. Yeah. For like minimal return. It's just crazy to me. But anyway, the Normatec is essentially sleeves that you can put your arms in or your legs, and it creates compression plus cryotherapy. And I think it pumps too. We don't have those. They won't have them here, but then the thought process is it's pumping fluid in and out while it's giving you the benefits of cryotherapy. I bet it feels really freaking good. And if that's a thing, again, if that relaxes you, yeah. This is what recovery is all about. It's about nutrition. It's about rest and sleep. Rest is not necessarily sleep.
That's so boring, Quinn.
I know, but here's the deal. Those things can help in your mind. They can help to relax you. So after a hard-ass training session, if you just straight up left after you already feel beat up, you just like walking out like you're still stuck in the squat rack, maybe you're not setting yourself up to tone down a little bit, get hungry again, and ramp down for bed, because you're still kind of amped up. But if you foam roll for 10, 15 minutes after your session, you stretch, you just lay on your back and breathe a little bit. Now you're setting the tone for that quote unquote parasympathetic shift that everybody, that these recovery modalities are supposed to give you. But I think that something like a Normatec where you're just chilling and it feels really good, I think that facilitates the mindset of rest and sleep. I just don't think the actual physiology of what it's doing, it's not specific to that apparatus. It just happens to feel nice. It's like a float tank. I think a float tank would be as conducive to recovery or sensory deprivation tank as any of these other things. It's really just personal preference. Another modality, the eStim, Mark Pro,
I was going to mention that. Yeah,
Compex units. It's the same, man. I mean, how blood flow. Exercise gives you blood flow. You know, it's all these things. You know, if I put a electrode on my quad, it's like, well, I'm inducing blood flow to my quad. But if I walk to my mailbox, I'm probably inducing blood flow to my quad too. So I don't know.
Yeah.
So it's like 50-50 here at they had a guy come with the power dot units, which is basically complex without wires. It's like handy. The app is on your phone, and they gave them to all of the Juggernaut lifters here, and people are just kind of 50-50 on it.
Mm-hmm.
And that's, again, it goes to this conversation, like, I don't know when somebody's going to be 50-50. I don't have a profile or a valid assessment to know if this is going to be the recovery modality that you like, or if it's going to be this one.
Got it.
Yeah.
So it's kind of like, you know, choose your flavor and just kind of try things out and find one. Because for me, like, therapeutic massage, you know, not massage designed to do something, but just like a feel-good massage.
Absolutely.
Like, freaking awesome. That's what I choose.
Absolutely. That's the same thing. It's relaxing. It feels good. That's awesome. Like, I think to me, that's evidence-based, because it's shit, like, you're relaxing, you know, you're taking it easy. So yeah, that's honestly how I stand. The Renaissance periodization guys that we work with, you know, Dr. Mike Isertel, Dr. James Hoffman, those guys, they dive into a little bit more of the recovery modalities that we talked about, or at least they dive into the literature. And I've been to several of their seminars. I've heard them talk, and the evidence is much like the evidence for different various manual therapies, where you may have a group that's subjective reports say that they feel better, they feel less sore. We just don't understand the exact mechanisms. That's all. And so if you've got indisposable income, like you're a clinic or you're a coach and athlete, and you've got an awesome facility, and you want to hook a room up with some Normatex and some Compex units and just have like a chill room, cool. You know, call it your parasympathetic chill room, and hit it on rest days. Yeah.
Eric, we need one of those at our new facility.
Yeah, man.
Awesome.
Yeah.
But I don't think there's yet a gold standard for that type of deal. Nothing trumps sleep and nutrition.
So say you are that athlete who just wants to just maximize things. We're talking about getting 8+ hours of sleep a night. Talking about eating in a caloric surplus. Training adequately and appropriately, so that you're not pushing things so hard, but you're still working toward progressive adaptation. What else?
Ramp down after training. Don't leave the gym. Leave the gym feeling better than when you hit your last working set. And so what I mean by that is, let's say it was a heavy deadlift, heavy squat, your accessory work, like shit's burning, you're like out of breath, or you're a little achy. You know what I mean? Like, you know that feeling right after the training session. You don't even want to clean your weights up. Make sure that you leave the gym not in that mode, because what's going to happen is you'll still feel like shit. You'll get into your car, you know, feeling like shit. You'll walk into the door of your house, and you'll probably sit down first thing, and then you won't get up for another hour. Like, you just start waiting, like, you know what I mean? So get on your back and just, you know, do some deep breathing for 5 minutes, foam roll, stretch, just move around, jump on the bike real quick, super easy, steady state for 5 minutes. And then you get up and you kind of feel more tied together, more connected, like you're reset. People hate that word, like reset, but you guys, I mean, it's just a general term for like, all right, I don't feel quite like shit like I did after I hit that last set of 8 or whatever.
Well, it's kind of like creating a ritual out of the training process.
Yeah.
You warm up,
definitely.
you train, you kind of cool down, or you know, find a way to leave on a positive note. Yeah.
I think you do the same thing with sleep. I think you have some type of ritual. Maybe you do a couple like little like movements, you know, T-spine rotation, or like a little light stretching before bed, something to just ramp down. It's all psychological. This has very, very little to do with physiology at that point. That was done in the gym, and that will be done when you sleep and eat. But I think the mental component of recovery is big. I think that preparation, you know, the warm-up is important, obviously. I think that people their warm-ups are a little bit too drawn out as far as the time is concerned, and I don't see the tempo and the focus of what a warm-up should be. So it's called a warm-up for a reason. Mm-hmm. You should literally raise your core temperature. You should actually get warm, and this is pretty clear. You're literally a better athlete. Your nerve conduction velocity is faster, more accurate. the viscosity of your muscle changes, the synovial fluid in your joints gets washed around the area. You've just prepared your nervous system. You're ramping up for training psychologically and physically, and so you need to literally get warm. If you're just jumping into your sets and you're taking no time to prepare your body before your working sets, you're doing yourself a disservice. And I think just that concept alone could prevent a lot of these wear and tear things. I had a guy yesterday. He has pain in his low back or like his hip area only when he gets up to about 85 or 90% of his squats. And I said, and let's say like 370 was his threshold. And I said, well, what's your warm-up set like? Or what are your jumps? And he said, well, I do the empty bar for 10 reps, and then I do 95 pounds for 5 reps, and then I do 135 for 2 reps, 275 for 2 reps, 315 for 2 reps, and then I'm on. And I actually think that I may have even added this there. Like it was ridiculous. Like 315 for 1 rep. It was singles after 135. That's what it was. Mm-hmm. And this is a guy who's not terribly strong either, and his movement patterns were, we needed to work on things. Like he was actually a strong guy. He was injured, and he was upwards and into the 500-pound squats, but like we were rebuilding, and those were his warm-ups. And so he's not honing the motor pattern. He's not practicing. He's not preparing his tissues because it's not enough reps. He's not getting warm at all. And then all of a sudden, he hits a certain percentage threshold and like he has pain. And so a big part of our conversation was just spend more time. You don't have to spend 30 minutes front loading your warm up with a bunch of stretches and like arbitrary drills, but spend time in the movement. I think weightlifters are much better about this than powerlifters. Granted, a weightlifter with a snatch and clean and jerk are dealing with weights that are far less heavy. The skill level, the motor patterning is higher, so you have to practice more. But just the general premise of chinking away at your warm-up sets a little bit, with a little bit more focus and dialing in. Maybe you're working on a positional fault, or like, you're trying to hone your technique, and you need that practice. It's like any other skill.
I agree with you. Yeah.
So that's a big thing. Prepare. Yeah.
Is it about a change in temperature, or is it just about achieving like a specific temperature? Like, we've got some buddies and some of our athletes down in Texas who are probably pretty lucky because it's hot as hell there all the time, which might lend itself to, less warm-up needed or better training. So you don't have to get as hot as like, I think it's just a change. I think it's a change. I honestly think it's more of a change in your nervous system. I don't think the core temperature has to go up that much. Like it needs to be the equivalent of a 90-degree gym in Texas. I think it's a small change in both core temperature and your demeanor and your perception. And then I think you have this ready state. That's a great, and that's variable too. That's a great question. I would love to see some data on that, if there's some specific cutoffs for true core temperature. So honestly, sometimes my warm up in Southern California, doesn't get super cold here. It also doesn't get super hot. Sometimes my warm up is wearing sweats and turning up the heat in my car on my way to the gym. And then this is physical therapist 101 here, terrible advice. But then I spend time with the barbell. If I don't have time to do all my little corrective type stuff that I give everybody else, I just spend more time with the barbell, but I at least get my core temperature up. I just don't know what the cutoff will be. That's a great question. Right. We're just talking best practices too. You don't have to be the paradigm every single time you step in the gym.
Yeah. But general guideline is use your warm up with focus and intensity and tempo. Don't spend 30 minutes and you've done literally, 2 half-ass stretches and then you warm up like that with these huge jumps. Don't expect things to improve, from a movement standpoint.
It should be deliberate.
Very deliberate. Yeah. Good word.
Since we're on the topic of, athlete habits, I did have some training specific questions. So what are your thoughts on core training for powerlifters and weightlifters? And I should preface that by saying that there's a camp that thinks that everything should be done with a rigid torso. So things like anti-extension, anti-rotation, anti-flexion, stuff like that. And then there's another camp that thinks you should be doing a lot of flexion and extension strengthening movements. So things like reverse hypers, weighted crunches, stuff like that.
What are your curls? You guys seen that?
What are your thoughts on those in terms of both strength and injury prevention?
These are huge questions, man. These are good. Woo. So core strength, I think that, and then the other camp is you don't have to do any extra core strength because the barbell is your core strength, right?
True.
I see many sides, and I see the argument, and I've done both, and I continue, and I prescribe both. I think that I see things like planks, like those are more lower level, like isometric core exercises are honestly for me more of a warm up, and because and people with low back pain or pain in general. Isometrics, like the active, quote unquote, activation work, like the muscle's going to activate regardless, right? But just feeling that burn, that's an inhibitory effect as well. And so I like isometric loading more so than even using my hands to get somebody to inhibit their pain because they feel muscle burn and they feel less pain. It's like doing clamshells when you have a little wonky hip, it like feels better in the short term. That's how I use things like planks and things like Palloff presses and different low level, more isometric, like rigid torso type things. I use them as more of a warm up for somebody who's in pain, and also to get somebody to ramp up, like a hard style front plank where you just hold for 10 seconds, but you really create a lot of tension and you drive air into that brace. I really like that to ramp somebody up. We do like 4 or 5 sets of 10 to 15 second high tension front planks. They get up and they're like hot. They don't need to do a bunch of stretching anymore, and they're all ramped up. I also like things like that for teaching people how to brace. Mm-hmm. I do think like the meathead stance of if you're creating circumferential expansion and you're bracing your trunk and you're keeping it relatively rigid through a squat or a deadlift, I do think that is your specific core training. I don't necessarily think that if a healthy weightlifter or a healthy powerlifter needs to do a whole bunch of extra rigid core stuff if they have that dialed in. Now, for a novice or anybody else who seems to have trouble keeping tension, that's where I use things like front planks or Palloff press or a static Palloff press or like super focused dead bugs, not for 20 reps where people are just half-assing and it's doing absolutely nothing. It's a very specific teaching tool for them to create tension, and then we're immediately on the bar and say, okay, you did that drill, you remember feeling that tension, or that's what you're going to do in your squat. So that's how I use those low-level exercises as kind of motor control, motor skill teaching tools, and we don't visit them very often unless they like to do them in the warm-up to ramp up. Now, as far as like weighted crunches or the stiffness versus the movement, I don't know if there's a right or wrong. Stuart McGill would say everybody needs to be stiff, especially powerlifters. You need spinal stiffness. There's really no reason for them to be fluid. I think that makes some sense for powerlifting. If you want to be as specific as possible, then you are keeping that trunk as rigid as you possibly can. That may be of detriment to you in your daily life because then you're like can't move. And then so that's maybe where things like a reverse hyper comes into play that can at least reintroduce some movement every now and then and give you back some of that variability. I don't think something like the reverse hyper is a training tool to get good at. I think it's just something to do at the end of training to decompress and feel better. And that's kind of the way I feel about like spinal, like moving through your spine in general. So going back to the notion of core strength, we do glute ham raises in a very rigid manner. I think a RDL is a great core exercise. I think a good morning is a great core exercise. We don't do a ton of like cyclical flexion under load, but hell, I've given people the Jefferson curl. Like Colin Burns, a American record snatch holder, was messing around with the Jefferson curl the other day, and
congrats to him, by the way.
Created a shitstorm. Yeah, I'll tell him. He's got a big chest the last few days. He's been walking around like a piece of shit. So yeah, bottom line is I think it's context specific. I don't think that weightlifters or powerlifters need a ton of extra core work if they have the bracing strategies already dialed in and they feel like they can remain tensioned and they are also happy with the amount of girth that they have. I think some hypertrophy of the abs can be helpful in a squat. I think just having a thicker trunk is helpful, and things like side bends and weighted sit-ups, ab rollouts like that, and lots of, GH raises, like that's going to build, hopefully, build a little bit of mass in the trunk. So yeah, I don't know if that answers your question at all, but it's
that's actually a super interesting idea. What you just mentioned about like building trunk thickness as a goal. Like usually people are like, I'm build thick legs, big ass, but like no powerlifter is like, man, I really need to just increase my midsection like diameter.
Yeah. But if you think about it, like that's the trunk is a transducer, right? It's going to transmit the force, and so if you have a thicker trunk, you won't lose as much power. You're not this little like me, like the skinny little twig that's flapping around in the wind.
Pinky Quinn.
Pinky, yeah. My index finger's too big. So yeah, we do it. We do that stuff sparingly, I guess. Like, and then we put a lot of stuff in the warm up to just jumpstart that, like potentiate that stiffness or that ability to brace.
To continue on what you're talking about, what you were just saying about the core being a transducer there, Quinn, from like a physical standpoint, right? Ultimately, be it a deadlift or a squat, more or less, we're transferring power through the body, right? You're moving the weight using a lot of the strength in your legs, in the lower half of your body, transmitting it to where the weight is suspended from, which in the case of a squat, it's on your back. In the case of a deadlift, it's suspended from your arms, which are attached to the shoulder. And so essentially from the upper back. So I like to use the weakest link in the chain kind of analogy with that. Whereas, if you're using the legs to create force, you're using the upper body to transmit force, you have to transfer that through your core. And more or less, if the core is the weakest link in that chain, you're going to have an inefficient transfer of power. And so do you think that there's necessarily any bad reasoning behind that to where you would want to, with like less than 5 minutes of core training, 2 days a week, you can get a lot done. And so I feel that it's a training habit that maybe I use too much, but I don't think it really takes away from anyone to regularly train their core outside of the scope of doing the lifts with good bracing.
What do you do? Give me an example of how you would train your core.
Typically, it would be like a post training. So someone, I'll usually alternate between I like the pal off press a lot because you had me doing that, and maybe this was a mental effect, but I felt like it made me more capable of bracing more effectively. I use kind of the intense planks, like what you were saying. They're kind of in the RKC style where you have kind of a little bit of rounding in your upper back and you're kind of tucking your pelvis in, getting that really, really tight core contraction. And then I like leg raises a lot too, just because they kind of force you to hold tension with that neutral spine. And more or less just a few sets of those 1 or 2 days a week. And that pretty much gets everything done that I want from people.
Yeah, I know. I like that approach too, and I also think it feels good when you're done with that stuff. Like you get up and you kind of just feel more connected, and that's another example of that, almost that reset position. I also we go back to tempos and pauses as core work. So an RDL where people typically will go extremely heavy and do it for reps, and that's great. But maybe they lighten the load and they're doing like a 5-second descent in their RDL. And they're exaggerating the tension in their abs. They're creating a surplus of tension with a lighter load. I think that can be great core training to teach somebody how to move. Like while they're moving, they can still breathe into that tension, which is huge. I think some people, they can either squeeze so hard that it looks like their head's going to pop, or they can do the movement. But they can't do the movement and keep the tension down, and pressurize that can. And I think just adding some tempo and pauses with lighter loads can be really, really great core training. And then all the, Hani, all the stuff that you said is fantastic too. Eric, going back to your question, I think stiffness should be trained in most core exercises if it's going to carry over, if it's going to be specific to the lifts, because our trunk needs to be stiff, whether you're talking weightlifting or powerlifting for the most part. I do, however, think that humans should be able to segmentally move throughout their spine. They should be able to demonstrate to me that they can do that. And so this is not necessarily and I say should, I think that for longevity purposes, to decrease risk of this chronic sensitization, the joints like to move. And so just reintroducing a novel stimulus, especially for a powerlifter or a weightlifter who the planes of motion are very constant and predictable, sometimes doing like one of the very simple just T-spine rotation drills post training to get things to move in a plane of motion that they haven't been. It's been cyclical. I think that can have a nice perceptual advantage or effect on somebody to just feel better, and that has nothing to do with the core. But we generally train the core through stiffness, and then we'll have maybe one or two other segmental mobility drills, but they're just still moving through their spine, just to demonstrate that they can. So there's that balance.
I'm smiling over here because when you're talking about T-spine rotation, like over the years, my spinal rotation laterally has been like progressively deteriorating. Like,
yeah.
Is that just part and parcel of being a powerlifter, or is that something that you can develop separately from your sport?
Develop
just the ability to move with good spinal rotation without having to like grab an object and force yourself.
Yeah. No. Well, so I think you asked two questions there. I think the answer is yes to both of them. I think it has everything to do with powerlifting. I think because you're not moving in that plane. You're actually trying to decrease motion.
Sure.
In every plane, and you're locked into the same position the entire time. And so it's now, can you develop it or can you mitigate the loss? You absolutely can. Somebody then would argue, well, why do you even care? And I think what you're saying is like, I at least want to be able to move as a human. And I think and so the good thing is like you've lost the mobility, but you've lost it only because your body's not going to allocate the resources for you to continue with that movement pattern. It doesn't mean that the joints have been fused.
Sure.
And you know what I mean? Now the tissues may have adaptively shortened a little bit, but you still have the motion in there. And so just even revisiting like I have a couple drills on my YouTube, just quadruped, thoracic rotation, sideline, just basic T-spine rotation 101. I think doing that stuff 2 or 3 times a week post training, a couple minutes, a couple sets all the way through, will do wonders to give you back enough to where you feel like you can still move during the day, but not so much that you feel now it's a hindrance to your ability to create stiffness. I do think there's a balance there.
Sure, that makes sense.
And I sometimes will use thoracic rotation as a correction, more so with weightlifters. And you guys have probably seen if somebody catches a snatch and they twist, we call it the helicopter, like you see, and you can even see that in somebody's squat too. If you look at them from behind, sometimes the bar is tilted, and you'll find that if you test their thoracic rotation, they rotate really well in one direction and almost roadblocked in the other direction. And it typically correlates to the side that they like to rotate towards. That's how they lift.
That's the less inhibited side.
Yeah, exactly. Now the reasoning, I have no idea, but then we will work thoracic rotation actively, very controlled, in a controlled manner to try to even them out if it's causing a performance enhancement or decrement. Sometimes that helicopter, like, it'll make you miss a lift because you can't control the damn bar. For a squatting, I don't think it's that big of an issue unless it's like really making them do something weird, like a crazy shift that's causing them to throw out of position with heavier loads. But T-spine rotation can be something that's maintained relatively easily, and also a correction even in a sagittal plane sport like powerlifting and weightlifting, to an extent.
Quinn, I wanted to take a moment to just like recognize how awesome weightlifting is and how much more difficult it is than powerlifting. Like just the skill involved in it. I don't think people appreciate how different it is in some ways from powerlifting, and what it takes to be a good weightlifter. Like, people focus on the number and they think like, oh, that's only 225 pounds over their head. Like, what's the big deal? It's a world of difference.
Try it. Yeah. I think powerlifting, I competed in a few powerlifting meets. I was just, the strength thing had a problem with that. But it's different. Like, powerlifting is very tight. Like, the meets, powerlifting meets are way more physically taxing than weightlifting meets. But the mental battle of weightlifting is just incredible. I mean, you can be snapping your snatches and your clean jerks one day, and literally like 2 days later, it's like you've forgotten how to do it. The neural component, the motor skill acquisition component is just, it's crazy. And that's honestly what makes a lot of people fall off, is like it takes years to hone that consistency. And even then you have these days. And I think in my experience, powerlifting has just been a little bit more straightforward. Like if you feel like shit, it's not because like the movements are too complex. It's probably because you just need to rest or something like that. Like it's a little bit more straightforward.
Yeah.
Yeah, it's a crazy sport. I think that's what's kind of kept me around, is like you're never good enough. You know,
It's this puzzle with all these new pieces to figure out.
Yeah, totally. And we make fun of like the way our gym is set up. The powerlifting is on one end of the gym, weightlifting platforms are on the other, and so there's this like divide, and make fun of them for not being athletes and make fun of us for being weak. So there's there's a lot of back and forth there.
Plenty of friendly hate to go around.
Yeah, just to touch on the gym setup, the way it is oriented, it does end up with the weightlifters watching the powerlifters and not the other way around.
It's true. No, it's very true. It's totally true.
So I'm just going to throw that out there. I don't know if it's because everybody likes to watch Chad squat or what, but
and the powerlifters work way harder. I mean, the weightlifters, like if you catch them doing a lift, you looked at just the right time, because otherwise they're going to be on the chairs like texting.
There's a lot of singles and a lot of chairs.
That's a big part of it. I've heard that's a big part of it. It's the texting on the chairs.
Oh yeah, you have to.
Superset snatch singles with text messages 10 by 1.
So Quinn, we've got a ton of other topics, and we're going to talk about them all right now. No, just kidding. I'd like to bring you back on another time to kind of go over a second batch, but it's been an absolute pleasure to have you on. I think the guests will really appreciate some of the insights.
Yeah, guys, thank you. Some of these questions I'll probably have to revisit next time. I'm honored to be on the show again, by the way, because they were so good. I need to preface my thoughts and organize them. So thank you. Yeah, it was an honor. I had a blast.
I expect a dissertation for your next visit on our podcast, Quinn. A full presentation, sources cited. No, really though, I don't know if I clearly communicated it to you. We really are grateful that you took the time. We have, a big part of powerlifting coaching is understanding and dealing with injury, and a big part of being a powerlifter is understanding and dealing with injury, and people really don't give it enough credit. It's like you said earlier, and I wanted to highlight that, but we kind of got sidetracked, but it's like, it's not a matter of whether or not you're going to experience some form of injury. A lot of times it's a matter of how to deal with the injury that you're experiencing. And that's almost, if you've been powerlifting for any measurable amount of time, odds are you have some nagging pain, period.
It's just going to happen. Yeah.
Yeah. And people don't understand that, it'll be, like you said, they'll blame themselves, they'll blame the programming, they'll blame their coach, or they'll blame their mother, whatever it may be. It's just, sometimes taking a step back and realizing that these things are going to happen, and being ready for it and being equipped for it is so valuable. So really, we are grateful that you would take the time to help us spread that knowledge and kind of better the community as a whole.
Absolutely. I have a little joke in my clinic when somebody walks in and they squat for the first time and their knees pop all over the place. So they're always embarrassed. Like, oh my God, listen to my knees. And I'm like, when somebody comes in here and their knees don't crack and pop, I'm like, you must be new. Yeah.
I think you said that to me, actually. I remember right the first time I came in.
So this is our first time having a guest on, and I almost forgot. I'm glad I didn't. I want to make sure to pimp you out a little bit. Guys, Quinn runs a website called The Clinical Athlete, which is a collection of practitioners around the nation that are kind of pre-screened to just know what they're talking about. And they share ideas back and forth, and just as a network of good providers. Am I right, Quinn?
Absolutely. And so with clinicalathlete.com, the directory is on the bottom, or the map is at the bottom of every page, and that's the directory. And so you can go on the site, you can search your area, and hopefully there's a provider, and all the clinicians have a profile page, and so you can get all the info there. We got a new website going to drop very soon, which will make it just easier for everyone. And
awesome.
And not, these clinicians, so I've, like you said, Bryce, I've screened them all. I've talked to them on the phone. I've met them in person. They're in a forum that we have that's private where we discuss these things. And so we actually have working relationships with all these. They're not all curmudgeons like me. It's like, so don't think, go on there and they have different skill sets, and they have different, experiences and expertise, but the overall theme is that they have a better understanding of athletes, and they're not going to be the doctor or the PT or the chiro that tells you to just stop lifting.
Yeah.
They're gonna help you integrate back into your sport. So yeah, that's what we got. It's been a great resource for everyone.
So besides referring a few people to you, Quinn, I've had some great success having people go on the website and find someone local that's really been able to just visit them in person and have some great interaction. So it's been helpful for a lot of our athletes.
That's great. That's great to hear, man. Thank you for that. There's no way. It's hard for us to track. We've got the map, and we want to know if people are using it. So I love hearing that.
Yeah,
absolutely. People are.
I think just continuing to get the word out about it. So Quinn, what's coming up next for you? Are you doing any seminars? Are you doing some traveling, competing?
Yeah. So the competing has been. That's just trying to find a weekend. They have this new American Open series where they have. So the American Open, the national championships, the American Open is kind of the second national meet, and now they have this series where it's they're all considered national meets and 3 all over the country, and I want to do one of those to qualify for the AO, and then maybe AO qualify for the nationals of next year. Awesome. The totals are going up, man, and it's good. Like it's starting to be the best of the best, like it should be in USAW, and so I'm going to have to work my ass off. We'll see. And as far as seminars, yeah, we got lots of them. We're heading down to New York or over to New York with the Juggernaut crew in February. And that's on the Juggernaut site. It's us, me, Chad, and Max Ada and Renaissance Periodization, and then we all have like another seminar the next day, so it'll be great. And I'm running this 2-day weightlifting course where essentially we break down the snatch and clean and jerk phase by phase and offer corrective strategies for both lifts. So it's a 2-day course, and there may be a book coming out soon.
Hey,
that's basically the course in the book form. It's been a long time coming, so that's all the details, but it's done. It's just being laid out and formatted.
Congratulations!
Now.
That must be a big relief.
Yeah.
Sweet. So is it going to be ebook or print version?
It's all everything. It's going to be print, ebook.
Very cool.
All the different. Yeah, we'll see how it goes.
Very
I might
cool.
just disappear after that thing comes out.
I'm glad to hear that you're coming out with a printed version of the book, Quinn. I've bought ebooks before that got mailed to me as loose leaves in a binder, and I hate that. I want to open a book and have it have a cover.
Oh,
man.
Yeah, no, this will be legit. It'll be a book, legit book.
Can I have you sign a copy? Is that something I can do?
Absolutely, yes, totally.
Awesome.
Give you my singlet too.
I would never wash it and wear it for all my meets.
He offered.
Yeah, it's been said now. This is going to be seen by at least 100 people who listen to this, and so. But really though, let us know where where can we find you on social media, Quinn?
Yeah, you can search. I think I'm the only Quinn Henoch on social media, so you can pretty much just type my name in Facebook or Instagram, and I'll pop up. Then the Instagram handle is quinn.henoch.dpt. You can just search my name on Facebook. I've got my coach's page and my personal page. Either one is fine. And then my emails are on both of those things as well. And so you'd be able to get a hold of me that way. And I respond to every message that I get, about the issues that you got going on. It may not be within the time frame that you would like, and it may not be the answer that you want, but I make sure that I get to everyone. So yeah, you can hit me up there.
That's awesome to hear. Actually, a lot of people are a lot of well-known names who people reach out to for advice of any kind aren't necessarily the best about responding to individual messages. Sometimes it's hard to keep track.
It's tough. Yeah.
You've got to get a bunch of emails every day. I know I do. I'm getting between like 30 and 50 emails daily. So answering 10 Facebook messages and remembering is a real pain in the butt.
Yeah, so you got to balance that with work and stuff too. So it can definitely take some time. But I get to everyone.
Totally. So we'll pretty much wrap up here, I think. Just so you can always find us on social media. All of the coaches are just their first name _TSA. So we've got Hani TSA right here, Eric _TSA, Bryce _TSA, Joe, our recently promoted intern to strength coach, who we're all very excited about. And I know Joe's worked with you, Quinn, and he has nothing but rave reviews for you, as well as Chris Aiden, who would be Aiden _TSA. He's the only one that had to be the non-conformer and use his last name. But final announcement, we do have a small surprise coming up on social media for the end of the year. We are going to be doing a giveaway of 12-week custom training cycles. It's going to be pretty fun. It's a $200 value, and we're going to be giving away 5 of them. So look out for that on Facebook, Instagram, and that's pretty much all I got, unless you guys have anything.
That's it. Quinn, it's been a pleasure. Thank you so much.
Yeah, thanks, guys. You guys are awesome.
We'll catch you soon.
Okay.
All right.
All right, Quinn. Have a good night, man.
Bye.
Bye.